Hi everyone, my name is Susan Elliott. I'm a nurse practitioner at St. Louis University School of Medicine. I do work in the Division of Geriatrics. Today I'll be presenting on correlating some of the 4Ms to patients assessment and coming up with appropriate interventions. So just a disclosure here, this project is funded by the GWEP grant that you see listed here, as is part of my salary. The objectives are to understand the 4Ms, be able to correlate our case study findings with appropriate interventions, and use an SBAR to facilitate some communication with providers and using good nursing judgment to fully participate in the interdisciplinary team. John A. Hartford Foundation developed the 4Ms age-friendly healthcare model. You see it listed here as what matters: medications, mentation, and mobility. And this is an overarching and overlapping type of model of healthcare. So you'll find that medications overlaps with the other three components almost all the time, as does what matters. It's the cornerstone of providing excellent care to older adults. When we talk about what matters, we're really concerned about what matters to the resident or the person if they're in the outpatient setting. So not what matters to the nurse, not what matters to the doctor, not what matters to family. Okay. When we're thinking medications, we're thinking polypharmacy and potentially inappropriate medications, and stopping any medications that we think might be causing or contributing to poor outcomes, such as falls or geriatric syndromes, including weight loss. With mentation, we're really concerned with the 3Ds. You see them listed here on the side: dementia, depression, delirium, and specifically differentiating between the three. Think back to our previous lecture where we went over the screening evaluation process for cognitive evaluation for the geriatric syndrome. So using the St. Louis University mental status exam to assess cognition, using the RGA to assess the frailty, the risk for weight loss, sarcopenia that might be impeding with mobility or performing ADLs, and with cognition. So lastly, we're concerned with mobility, and specifically we're looking at maintaining function, promoting independence, and performing our activities of daily living. All right, this is a nice graph, table rather, that differentiates the symptoms of the 3Ds. It's part of the seminal article from Downing et al., who coined the phrase the 3Ds. Dementia, you'll find, is chronically progressive, and that's how we tend to tell that apart. It's the onset over months to years, versus delirium, that is a rapid onset of progression of disorganized thinking. It's a medical emergency. It requires further evaluation so that the physiological component of that does not progress to become life-threatening. Depression can be more variable, but what we see most commonly is the lack of motivation. Listed below are the prevalences that we see in the EDs, which I feel is probably underrepresented. Again, a refresher on cognition in nursing home residents. What portion of nursing home residents have cognitive problems? And the answer is a lot. In fact, 73% have dementia, 14% have mild cognitive impairment, leaving only 13% in the normal cognitive functioning range. So now let's get to our case study. Think back to the lecture that we gave before, and all the interventions that we talked about and the assessment scales that we use. And then let's talk about Blanche. So Blanche is an 87-year-old white female. She lives in a nursing home. She's more forgetful over the past months. She's been staying in her room a lot, mostly in the recliner. She's not finishing her meals as before. She worries about everything all the time, say the staff. She doesn't want to do much because her feet are puffy. And the staff think it's because a right ankle wound that might be infected, and they want you, the nurse, to come take a look. So she has a history of high blood pressure, chronic kidney disease, high cholesterol. She's had a stroke. She's got some diabetes, some neuropathy associated, and then she's falling. She does have a family history of Alzheimer's. She could tell you her dad had Alzheimer's when you ask. When you ask her what's going on, she feels sad, but she can't really elaborate on how or why. Um, she doesn't have any problematic symptoms like chest pain or shortness of breath or painful urination. Um, but when you ask her about pain, she says all the time. Doesn't really say how or where. So let's look at her meds and give you a chance to absorb these. We've got some PRN Tylenol available, 1,000 milligrams up to 4 times a day as needed. Amlodipine, 10 milligrams daily. So this is her blood pressure medicine. Atorvastatin, 80 milligrams daily. And remember, this is a high dose for a statin drug, and that's because of her history of stroke. She's on a full strength aspirin, 325 milligrams daily. That's to help with the blood thinning because of the stroke. Her clonazepam that she takes 0.25 milligrams 3 times a day around the clock is actually a long-acting benzodiazepine. Takes a long time to wear out of the blood. And then she's on clopidogrel. So this is Plavix. This is another type of blood thinner, 75 milligrams daily, and this is that stroke again. And then she's on gabapentin, a pretty hefty dose, 900 milligrams 3 times a day. And this is for her neuropathy. She takes a long-acting insulin at bedtime, and she's on sliding scale if she needs it through the day. And in addition, metformin, 500 milligrams twice a day. Keep in mind that this is not an optimized medication dose. It can go up to 1,000 milligrams twice a day in most patients routinely that need it. Miralax, she's getting daily if she needs it, and then she's getting her finger poked 3 times a day and before bedtime. So here's the vitals. You'll notice there are one teens over 60s. When you look back through the chart, you don't see any pressures that are really over 120. She's got a normal weight. She's sitting well on room air. Her blood sugars are really good if she was 35. But an older adult, these blood sugars would fall into the over-controlled range. 62 is very low, so is 87. And then even the 105 and the 112 would be alarming to me. The 154 and the even up to 202, I'm okay with that. And when we try to control adults, remember, we're thinking an A1C and the 8 range per the guidelines. And you'll notice that Blanche's A1C is 5.2. So we're definitely looking at a picture of over-controlled blood sugar. Her slum score, 11 out of 30. Think back to the scoring guideline, this puts her solidly in the dementia category, which is 20 or less if you've had a high school education. The GDS, which is the Geriatric Depression Scale, is 8, and it does show signs of depression. And remember, the GDS is easy for our older adults to participate in because they have yes/no answers. Think back to that PHQ-9 and how you have to reflect over 2 weeks' time and rate each symptom on this big scale to give points, and a lot of people are excluded by that. When we look at our geriatric syndromes, she is frail. So she has a score of 3. If it was 1 to 2, that would be considered pre-fail. Her SNAC score of 11 shows that she's at risk for losing 5% or more of her body weight in 6 months, and that's if the score is 14 or less. The SARC-F is positive for having a sarcopenia, and remember, this is the translation of muscle mass loss into loss of function, okay? And this might be going on with Blanche. When we look at her labs, she's got a low hemoglobin, 10.2, so she's anemic, and she's got a high MCV value, which we often see with B12 deficiency. Her sodium shows that she's at the top end of normal, so she's probably a little dry. Our dementia patients often forget to drink, and so they require prompting a lot of the time, so keep that in mind for your interventions. Her kidney function looks like it's probably decreased. A person would have to do the math if you want to figure out the GFR. Her protein levels are a little low, 5.4, and albumin 3. So this is telling you that, maybe she's not eating as much as she used to. Maybe she didn't get enough protein in her diet. Maybe she's not using the calories well. Her thyroid, so the TSH 6.23, normal people we keep in the 2 to 4 range, but older adults, the guidelines reflect what happens in real life and aging, which is that the TSH value goes up a little bit. So getting upwards towards 8 is still in the okay range for older adults, so I'm not real worried about that. That B12 level is low at 187. Remember, even normal values of B12, if they're in the very low 300s or in the high 200s, you can actually have functional deficiency with and have symptoms. All right, so you get to your exam, you note that she's elderly, she's tearful, she's anxious, and she repeats her questions to you throughout your encounter together. Her glasses are missing, her dentures are in a cup, she does not have her hearing aids in. They're over there on the dresser on a charger. Her lungs are fine, she's got a regular rate and rhythm. You're not really worried about anything on that. She's soft, non-tender. She doesn't have flank pain. She doesn't have suprapubic pain. She is unsteady with her walker. This is concerning. And she's got that lower extremity edema, 1+ in the lower legs, 2+ for her feet. And then when you ask her orientation questions, she knows her name, her birthday, she knows where she is, but she really doesn't know the date or even the month for that matter. And previously, the staff say that she was ANO to 3 months ago. Now, you take a look at that wound. It's on the right medial malleolar surface. It's 3 centimeters. It's got some raggedy edges, clear drainage, no particular pain when you do your palpating, and it's not erythema. Does not have erythema or warmth when you touch. You're really not very concerned as a nurse that this would be infection. Okay. So now let's get to our care plan. What matters to Blanche? Well, we have to ask Blanche to know that answer. Now, she probably needs a goals of care discussion and a code status discussion, right? So the question is now, how are you going to begin the conversation? And the answer is you begin the conversation by starting it. A lot of people shy away from talking about difficult issues with older adults because it's, not something that we all feel comfortable with. But in reality, older adults go to the hospital all the time, and the cascade of care that they receive by being a full code person, they may not have really signed up for. They don't know what's down the line for them, and we do as people that work in healthcare. So it would be important to start with an open-ended question and say, Blanche, have you ever talked about or thought about what might happen if you can't talk for yourself with your care? What would you really want done? And just let her start the conversation, because now you have a foothold in. You could say things like, would you ever want a breathing tube put down your throat and into your lungs so that you could breathe if you weren't able to breathe on your own? If they did this, sometimes it's very hard to come off a breathing machine. Would you want your family to be able to then have to make a decision of whether to come off that breathing tube or not? Would you want a feeding tube to be put through your skin and into your stomach, and they would use liquid food that goes into your stomach to keep you alive because you can't eat food? Is this something you would want or not? If you did want it in the beginning, how long would you want that done? People can, when you give them real questions, they usually can provide some answers or at least some insight. What you're looking for with Blanche, because she has dementia, is you're looking for her to be able to provide an answer and support that answer with a rationale of sorts. Okay, so even people with dementia can be decision makers in their care, especially for her since she doesn't have an MDPOA, right? So, but it's the ability to digest what you hear come up with an answer and support it with a rationale. That's what we're looking for decisional capacity. Being competent to make a decision, that's 100% different, and that's something that the courts decide. Um, but so you only can know some of these answers by starting the conversation. Once you carry this conversation on with family members, it becomes a much more tricky subject to discuss because families tend to think in emotions rather than logic, even if they're logical people, because this is mom, right? So this is, you'll learn the nuances on how to approach family, but I find personally that if you start conversations with, we want to make sure that we get things right. What would Blanche would have wanted for her care? Has she ever talked to you about what she's wanted? And what this does is it kind of guides family into thinking about what their mom wants instead of what they want. And if you don't redirect families, what you find is they think about, oh, well, I want everything from mom. You will do everything until the very end. They don't have a concept of the big picture of what happens. They certainly don't know about how many older adults that have some type of a hypoxic event that requires them to have CPR, how many people actually return to baseline after that. Maybe families or residents might not want to have CPR if they knew how low those percentages are, and they are quite low. So, what if family disagrees on how to move forward? Well, the answer is they always disagree. We really need to try to narrow it down to one decision maker. A lot of facilities are very good at this. They'll put a number one and a number two contact in that you start with. But this is why advanced directives are so very important. We need a single decision maker. You really should be established before a person has memory loss so that the process is smooth. So hopefully that helps. With our mentation recommendation, what is your suspicion level for delirium? I can tell you that I heard months. I heard family history of dementia. So my suspicion level for having delirium is probably pretty low. I definitely would do a med rec. I'd be looking for things that could be causing delirium or dementia for that fact. They're often the same thing. I can tell you her medication list had several medications on there that would be problematic. I'd be looking at labs, recommending to make sure that we're not looking at a picture of dehydration, because you remember the last time her labs were checked, she had a high normal sodium. I'd be looking at other metabolic reasons, right? So you can have organs that dysfunction and infections and everything else. So I definitely would recommend a nurse to ask for labs in this scenario. Would you recommend a UA? And overwhelmingly, that answer is yes with students when I give this lecture in person. But the reality is, altered mental status alone is not an indication for urine testing. A lot of our older adults are colonized. So when we do test the urine, what we find is bacteria. We call it a UTI, even though it's not, and we treat it with antibiotics that then furthers the amount of resistance that we have in the community. So, unless you have local symptoms, and think back to your exam, there weren't any, we really don't have a reason to ask for a UA. Now, with her dementia, 11 out of 30 is definitely something that is problematic for Blanche. This is on the radar, but we really haven't ruled out that pseudodementia. And remember, pseudodementia is the cognitive decline that we see in correlation with depressive symptoms. So once you fix the depression, the cognition tends to make it back to baseline, not always. It is a precursor for later more permanent dementia, which is we cover that in detail in the previously recorded videos. She also has history of stroke, so you have to assume that there's a vascular component to her memory loss. So I'm worried about appropriate level of care. Is Blanche in the right spot? Does she need more attention by specialized staff on a dementia unit that might be able to prompt her to take in fluids 3 times a day, or maybe some feeding assistance if she's not eating enough, or noticing that she's not eating enough? Maybe offer things like finger foods and whatnot. The sensory aids have to be in place, the end. So we have to have the hearing aids in, the glasses on, because these things stimulate the brain, like mentioned before, and she needs every opportunity to think clearly that she can have. In the previous recorded video, we talked a lot about meaningful activities and how they have to be tailored to the individual to be meaningful. So music therapy we find very helpful in older adults with dementia and actually anxiety with depression. They also decrease social isolation and loneliness, which is something that I think Blanche is dealing with. And then if we really have to reach for a first line therapy, because remember, our goal is to control the anxiety with depression, to see if her cognition gets a little better. We're reaching for things like an SSRI. So these medications are very safe in older adults, and they're well tolerated, two in particular, and that's your Zoloft and your Lexapro. And remember, your Lexapro doesn't throw energy. It's a non-energizing SSRI. Escitalopram is the generic name. And so for someone like Blanche, I would be most concerned with using a medication that did not add to her already problem of worry. And when we put an energizing medication, much like a Zoloft, what we see is that can aggravate the person's anxiety. So think about those things. With our mobility recommendations, I'm most definitely evaluating the medication list again for hypoglycemia risk. Remember, she's on insulin with over-controlled A1C and over-controlled blood sugars that borderline on actual hypoglycemia. She has a fracture risk because she's falling. So what are some of the things that we would want to start or stop? Think back to the medication list. Again, there were definitely some things missing, and then I would be most concerned with her insulin. And we'll discuss that more on the next slide when we get to medications. Again, meaningful activities, I would include the daily activity where she's up and moving and encourage those ADLs. My question again to students when I give this lecture in person is, would you ask for PTOT? And overwhelmingly the hands go up. But in reality, you have to think about dementia's effect on Blanche with her ability to remember what she learns, right? So when you're in physical therapy, you're learning how to use a cane, you're learning how to use the walker, you're learning how to change your gait so that you're safer. These are things that someone with dementia can't do. So the long-lasting effects that improve outcomes from physical therapy and occupational therapy are often not benefiting a person with dementia. So a lot of times I'll try to have an evaluation done and let PTOT see if they could pick her up for some reason that might help with a little restoration. But a lot of times I get told no, that with the dementia, she's really not going to benefit from any lasting effects. And so think about that before you make the recommendation. I never knew that before I actually worked in long-term care. I am concerned about the lower extremity edema and the pedal edema. So I'd be looking for contributors on her med list. I can tell you she definitely has contributors, and we'll get to that on the next slide as well. I would be recommending compression. It's the safest way that older adults can have controlled lower extremity edema without diuretics that make them feel worse. And remember, Blanche is already at the top end of normal on her sodium, and she already forgets to drink probably because of her dementia. So I don't think I would be recommending diuretic of any sort unless she had a real reason for it. I would be encouraging her to be up and moving, because remember, the muscle pump squeezes that blood back to the heart, keeps the edema from happening in the first place. And I would be recommending protein intake, because you have to have protein to heal wounds. You have to have protein to make red blood cells, right? So she's got anemia that could be causing her weakness. So she needs protein. I would also be looking at pain medication administration timing with regards to her pain. Remember, we want Blanche up at least 3 times a day and out to the main dining room eating. If she's in a lot of pain, she might not be willing to do that. I'd be looking at maybe a scheduled Tylenol, maybe 3 times a day to be effective, so that she feels better when it comes time to mealtime. Why is it we don't pick a PRN? Well, people with dementia forget to ask, and then by the time they ask, their pain is already out of control. We do need to assess for pain in people with dementia. Sometimes it's not as easy as getting a pain scale, because people can't rate on the scale, but there are behavior type of scales that you can use, like the Alzheimer's pain scale. And then don't forget your non-farm pain control. I mean, something as simple as elevating legs can help with pain from edema. So, and there's lots of different non-farm interventions that you can make. So now to the medications. She's on a statin, and not just a statin, she's on a very high dose. And remember back to our previous recorded lecture about how statins take a long time to work, on average at least 2.5 years, to prevent 1 out of 100 major cardiac events from occurring, and that's without a reduction in mortality risk. So does Blanche have 2.5 years to benefit? And the side effect profile is very high for statins, right? So you get muscle and joint problems. It causes foggy thinking. These are all things that Blanche doesn't need. So she might be taking a statin and getting all the adverse drug effects and none of the benefits. So consider that when we make our interventions. That clonazepam, again, very long acting. It's on the Beers list, which is the do not use in older adults if you can help it, right? It contributes to cognitive impairment and falls, as does her gabapentin. And she's on that very hefty dose of gabapentin. At the very least, I would be tapering down on the gabapentin, and I would be tapering off on that clonazepam. Consider the effects of amlodipine on her leg swelling and her puffy feet, and think back to what Blanche's blood pressure actually is, right? So she's in the 1 teens, she's almost always under 120. And our older adults, as I alluded to in the previous recorded lecture, really do better with blood systolic pressures of 130 or higher. When we have lower, we're not really perfusing the brain as good as it could be. People have falls, and there's an early risk of mortality that's increased. So I would be thinking that the BP is low, that amlodipine could go all together. Okay. But if you did have to put something back, I'd like you to be thinking about what the next better choice might be for someone. And someone with a little bit of kidney disease, you might be reaching for your ACE inhibitor, like a lisinopril, because that's kidney protective. But I don't know that I would recommend that all too soon. I would probably say monitor, so that we can see what the blood pressure really is off these meds. There's the insulin. Again, blood sugar way too tightly controlled. She does not need an A1C in the 5s. She doesn't need her nighttime insulin. She does not need sliding scale insulin. I would probably make recommendations for both to be gone, especially because she's falling, and hypoglycemic events can have very bad outcomes in older adults. Her blood thinner, she's on 2 different kinds. Yes, she's had a stroke, but does she need both types, and especially the dose of aspirin? Remember back to our other lecture, aspirin at 81 milligrams is as effective as a 325. So that by itself should be 81. And then you have to make the decision, does she need both? Probably not with her falls. As a provider, I would be thinking probably not, and I'd be stopping one. In my case, I'd probably even be stopping the clopidogrel and picking just the baby aspirin because of her repeated falls and her decline in function with her dementia. So I would be looking at a more conservative approach to anticoagulation. Some providers might keep that clopidogrel until they really see the writing on the wall that says, yes, she's falling too much, she can't handle it. But I would be worried about a head bleed. Now let's talk about Tylenol. Tylenol in younger adults, we see the orders every single day, less than 4 grams in a day. It's on every order set, right? But in older adults, it's actually less than 3 grams in a day. And almost all older adults have too much Tylenol available to them. So think about what you would do based on pain, not getting up and moving as much. We talked about scheduling her Tylenol maybe 3 times a day ahead of meals to promote her being up and out of that recliner a little more. So typically the dose that I reach for is 650, which is the arthritis strength. I use 1 tab and use it 3 times a day. And then if we have to add a 4 times a day in there and take off the 3 times, that's fine. A person could always do that. Tylenol really does well at keeping baseline pain levels lower. It doesn't always work well for getting out in front of pain that's already there. And remember, Blanche has dementia, so I'd make sure to recommend a scheduled dose of Tylenol in the safe range. Now, what is she missing? So we saw that she had low labs for B12. She has associated neuropathy, and she has decline in cognitive function, right? So all 3 of those things, along with her anemia, point to the fact that she needs a B12 supplement. And then all older women, older adults need to be on D3, especially if you're falling, to try to build up bones to prevent fracture. All right, so how are we going to communicate what we see with the provider? And so the situation background assessment recommendation SBAR form is the best way to do it. I'll be honest, I most of the time have nurses do the first 3 and not the last one. So they'll give me an SBA. They'll tell me what's wrong, and then they'll ask about, well, what would you like to do? Please advise. Would you like to start orders? But they don't make recommendations. And what I need nurses to do, and to understand that they need to do, is they're the person in the environment that sees the patient regularly, and they can use the nursing judgment, use the critical thinking to make recommendations, and point providers into the right direction. If they don't like the recommendation, they don't have to follow it. If I had a nurse that made a recommendation that was wrong, I would say, well, I probably wouldn't do that, but here's what we can do. So it's a starting place. So with Blanche, her situation, of course, is that she has a physical and cognitive decline. She likely has dementia, because remember, you can't diagnose it as a nursing diagnosis. It's a medical diagnosis. So you can say she likely has dementia. She likely has depression. We've got some bilateral lower extremity edema. She's got a lot of meds and some of the wrong type of medications, which is a potentially inappropriate med or a PEM. She's falling, and she's got some chronic pain. And on top of that, the background is that, she's been isolating, she's less mobile, she's tearful over the past weeks. And then go ahead into the objective assessment data that includes her slums that indicates dementia, her GDS score that indicates depression, her BP being low, her blood sugar being low, her A1C being low, her B12 being low, and she's a fall risk on top of the edema. So I would word my recommendations kind of like below. You can use whatever method that you want to use for your recommendation, but sometimes it's a tricky thing to recommend starting or stopping a medication from a nursing perspective to a provider. So here's how I'd put it. I would say she needs a med rec, code status, and a goals of care discussion. That's for sure. She would benefit by tapering off her benzo because she's falling. Would you like to start an SSRI instead? Um, can we GDR, that stands for gradual dose reduction, her gabapentin because of falls? Does she need her statin with her advanced dementia? All right, so you would be essentially planting seeds that the risk is higher than the benefit and the time to benefit. She has leg edema and she's on a calcium channel blocker, amlodipine, and she has low BPs. Can we stop it? Um, do you want to start B12 for her low B12 level? And she has neuropathy. Can we start Tylenol 650 3 times a day to help with her pain and get rid of that PRN since she has more than 3 grams available to her in a day? Can we start compression hose for her edema? And would you like to start D3 because she's falling? These are all very good suggestions. I would highly encourage every nurse to utilize your nursing judgment and to communicate actively on the interdisciplinary team because you're a valuable member. You have more time with the patient or the resident if they're in a nursing home than the provider does. So you have valuable information to share. So that's my input. Let's see. And then that brings us to the end of the discussion. Here's some of the references that I have available for you. You can always pose questions to our department. Happy to answer those. And I hope that this conversation was helpful, especially when it comes to goals of care, what matters, and things that older adults really do need. On their behalf, right? So just modeling all of your interventions, they inevitably will fit into one of those 4 M's. It's an excellent way to provide care to older adults.